So welcome, ladies and gentlemen, once again to our speaker series. We are thrilled to have with us Audrey McFarlane, the founder and current executive director of Lakeland Centre for FASD. For those of you that don't know, the Lakeland Centre for FASD was actually first established 25 years ago, and it really started with Audrey having a dream and recognizing that in order to really support people with FASD, that it needed to start with diagnostics. And so what Audrey is going to be sharing with us today is how she managed to start this 25 years ago, everything that she's learned along her journey, and finally, what things that we should keep in mind as we begin establishing our new diagnostic clinics here within Ontario. So again, Audrey, thank you for joining us, and I'll turn it over to you.
Perfect. Thanks so much, Rob, and thanks for inviting me. This is one of my favorite topics to chat about. So I will just correct you, though, that I am not the current ED of Lakeland. I have moved to a new position of ED of the Canada FASD Research Network. So, but I was the ED for 20 years, and as Rob said, I was there when things started. But certainly didn't do it alone. Rob makes it sound like I single-handedly did all these things, but as you will all know, it takes a great community and a great number of people to make something like this work. So today I'm gonna talk a little bit just about a bit of the background about diagnosis, but I think it's important for you to understand the diagnostic process, which will help to understand how it all kind of comes together in a community-based model. I'll tell you a little bit about Lakeland, and then, as Rob said, I'll talk about some of the things I've learned and some of the recommendations. And then I also want to tell you a little bit how CanFASD's work feeds into the diagnostic work that you might be undertaking. So I know that most of you are very knowledgeable about FASD, so I'm not going to spend a ton of time on these things, but just to let you know that Canada does have FASD diagnostic guidelines. We're one of the few countries in the world that has national diagnostic guidelines, and they came into effect at the end of 2015. The clinics in Canada are almost all using these guidelines. They are a best practice, and of course use a multidisciplinary team approach in their recommendation. And it really does provide a consistent approach across Canada, which when these guidelines were developed, I was part of that process, and we used the evidence, the research at that time, to inform how we would do diagnosis and what would be diagnostic and which would be informative. So that was quite an interesting process to come up with, but just so you know, it's based on science. So in that, we moved away from the American model, which was either the 4-digit code way of looking at things that the University of Washington developed, or the Institute of Health. And so we moved to a diagnosis where FASD was the diagnostic term. And so FASD with the facial features, FASD without the facial features. And then we developed an at-risk category because we were seeing a lot of either very young children who didn't meet the criteria, but what we suspected would in time, or that the person that was being assessed had so many other issues that they maybe couldn't determine that they were all associated with prenatal alcohol exposure. So we developed this at-risk category, and it's intended to get people services and that they would come back to clinic at a later date to get a confirmed or not confirmed diagnosis. When we do diagnosis, we do assess 10 areas of the brain. And this is important to know which 10 areas, because this helps to decide and determine which people, which team members you need to recruit so that you can assess all 10 of these brain domains. And I'm not going to spend a lot of time on this. You probably all teach this in your own jobs. So. But the diagnostic process is, there's a number of different steps, and I'm going to walk us through some of them. So we have your referral or intake. You have that acceptance of that referral. We need to then schedule all those assessments and hold the actual diagnostic clinic. And then there's reports and recommendations that follow. So in the referral or intake process, we need to verify that the referral meets whatever the clinic criteria might be. So you need to decide age, what assessments might be needed. Are you going to require prenatal alcohol exposure as part of the referral process, or is that something that your clinic coordinator will investigate? And what's the geography area that you need to stay within. So those are some of the things that just at the very first glance that you would look at for those referrals and intakes. And then, so some clinics do require that PAE to be confirmed as part of the referral process. Some require that the individual has an updated IQ test when they come in for clinic. And some clinics require that all assessments be included, all previous assessments be included with the referral package. And then you do need to ensure consent. So not all the individuals that you see will have a biological parent with them. So you need to make sure that you have the right consent in place. So once you kind of decide, okay, this person meets all of the criteria that we have set down, then there's completion of intake forms, a number of consents. You are going to try to collect all the previous medical reports, all the social history, all the previous school information, placement history, all that sort of thing. You're going to confirm the prenatal alcohol exposure. So of course, if mom is involved, this is a conversation that you would have with her. But if not, then you look within all of those reports that you've collected to see if you can't confirm prenatal alcohol exposure or talking to other family members. And so there is some criteria level here. I'm not going to get into a whole bunch of it, but this is a fairly delicate area. This part of the intake can be a tremendous amount of work and take a lot of time. And the role of the clinic coordinator becomes one of detective, trying to track down all this information. And if your clinic is going to see adults, this can be a real challenge to gather this previous information. Sometimes health services destroy records when the person turns 18. Sometimes schools do that. So it can be really difficult, and you have to get really creative about where you're going to find this information. And so then your wait list may have different layers to it. So people that are at the intake stage, people that you're collecting information on, people that you have all the information on, and they're all ready to go to clinic. So you end up with kind of different levels and layers of wait lists. So then once you gather all of that background information, because FASD is really a diagnosis of elimination of every other possible thing. And so that's why we collect so much of that previous information. And so once you have all that, then you're going to share those current assessment or that past assessment information with your clinic team members. Your SLP will get the previous SLP reports and OT and so on. And then you will schedule appointments with each of those professionals. Now, sometimes that happens all on the clinic day, and sometimes that happens prior to. The list of assessments is quite long, so lots of clinics have pre-appointments for especially the psychologist, because if it's a child, they can get quite tired if everything is done in one day, and you want them to be at their optimal. So that can be confusing for families to have a number of different appointments. So again, the clinic coordinator helps guide the family through that process and make sure they're understanding why and where they need to be for each of those things. And we do recommend that if you're seeing adults, that you try to link them to some sort of support advocate to assist them through that process. That can be well, as you know, it can be challenging sometimes for adults to make all their scheduled appointments if they don't have support. And then you confirm the actual clinic date. So on the actual clinic day, you bring your multidisciplinary clinic team together. They review the history that you've gathered, and the clinic coordinator often does a summary of that history so that you're not reliving the history, you're just getting a summary of it. You review the results of the previous assessment and the current reasons for the person coming to clinic. The clinic team members will then kind of split up, and some will interview the family, some might interview the school or other support systems depending on the situation. And this is these interviews are really important. They're an opportunity for the clinicians to confirm that the reasons why the person's there, to get a sense of what the current situation is, and to really hear what the family and the support systems need in order to support the individual. Then the team gathers together, they formulate the diagnosis based on the diagnostic guidelines, and they make recommendations. Then they communicate that usually on the same day, that information to the family and or the adult, this is then followed up with a debrief with the individual or the family members, usually a one-on-one situation with one of the clinic team members. So then there's quite a bit of paperwork that usually follows. So a medical report is developed and made sure that it gets to the family or the guardian if it's social services. It is usually signed by the clinic physician, and then the family can use that to connect to services. It can be it's really important to make sure that the clinics are connected to that post-diagnostic support system, so that that people are connected fairly quickly. And I'm going to talk about who's on the clinic team in a moment, but that is a good consideration to bring some of those people in actually to the clinic table. So a lot of the folks that are on this call might actually be part of a diagnostic clinic team, and they can hear firsthand some of the issues, and then they're better able to support families post-diagnosis. Then there's file storage, of course. I mention this because it becomes a big issue in a community-based clinic. Where do you store these files? And at Lakeland, this post-clinic support, we felt at the beginning when we started, because there wasn't any informed FASD services and there wasn't any specific FASD services, that follow-up supports was critical and ethical to make sure that we had them involved when we started doing diagnosis. The world's a little bit of a different place now, and so there's a bit more support on the ground. So this is who by the diagnostic guidelines is required to be at the clinic table as best practice. There's no one standing over you and saying you must do this, but it is what is recommended. So for children's teams, a physician or a pediatrician, neuropsychologist or a psychologist. We're going to talk about psychology in a bit, but a speech language pathologist, an occupational therapist, and a clinic coordinator. And for adults, slightly different, a physician or a psychiatrist or both, a psychologist, an occupational therapist, and a clinic coordinator. Now, some teams do include speech language pathology on the adult team, but most places, SLPs for adults is a really limited opportunity. Like there's not many SLPs that, that specialize in adults. So then you may want to think about, especially on a community team, who else you might want to include on that team. So you may want to include somebody to support the team in understanding the culture. If you have a lot of Indigenous folks or communities in your region, in Lakeland, we had a number of different kinds of Indigenous groups, but we also had a military base that had its own culture. And so we needed to consider that as well. And we also had a very large Francophone community. And then there was, it's a very metropolitan kind of area for sure. And then we had this community of, they're called White Russians. It's kind of like Doukhobors or Hutterites. So we also needed some cultural liaison with that community in order to understand what might work and what might not work in those communities. This was such an important person on the team, especially in some of those really tiny communities when you go to make recommendations and you want to make sure that you're making recommendations that really support the family. Things like, I wouldn't make a recommendation for the child to see the counselor on the Métis settlement because that's this mom's ex-mother-in-law. You know, those kinds of things that you get into in rural communities, that these subtleties that can make a real difference in whether people actually go for support or not. And understanding some of those nuances can be extremely helpful in having good outcomes for the individuals. So some of the other folks that you might want to consider might be somebody that actually works directly in mental health services or probation or policing. I've seen both models work very well, having that justice component, especially for youth, and especially if there's justice involvement for the individual. Employment supports on an adult team. This can be really helpful in terms of recommendations. Children's services and child welfare can be extremely useful at the clinic table to help to understand some of the childhood experiences that you might hear about. So if the child had, you know, this kind of a back and forth arrangement with the birth family, or the person had 27 placements, this person can really help to explain what was happening in those. And it just gives a sense of what kinds of supports the person might need, and really helps the clinical team to understand what they might be seeing in terms of brain domain. Is it trauma? Is it environmental? Is it actually prenatal alcohol exposure? We talked about post-clinic support that could be involved. Addiction services for youth and adults can be very helpful. And then lots of clinics have kind of a volunteer parental support person there that provides some guidance and you know, hand-holding for the parent that's there, and that can be very, very helpful. So these folks understand the community. They can add to the understanding of those brain domains, and they can certainly add to those spiritual, cultural supports. So really, I mean, I really love this part of the clinic team, obviously. So there's lots of ways that clinics can be set up. They can be in hospitals. They can be, you know, your regular developmental pediatric clinics. They can be in other facilities. We're starting to see emergence of clinics within jails, mental health institutions, even schools have taken the lead. There's a couple of places in the north where schools are pulling together the multidisciplinary teams. There's private clinics that are emerging. There's blends of hospital communities. So for example, the Glenrose Hospital in Edmonton, Alberta, they have a developmental pediatric clinic in the hospital, but they invite those community members into the clinic process to support them. There's some virtual models that have really emerged, and some hybrid models, you know, part virtual, part not. And this can be really useful as well, especially if you don't have those specialists in your area where you need to have an SOP or something, and then you can launch those in. And Lakeland, just before the pandemic, had received some funding to do a pilot on virtual clinic and to see whether you could actually do the assessment pieces virtually, not just the conversation pieces. So that those papers are written and available as well. And then of course, my favorite, the community base that we've been talking around. So this is usually a not-for-profit or some sort of legal entity that runs this in order for you to get professional liability insurance. It usually operates once or twice a month, but can operate more frequently. Employs a clinic coordinator. So I would strongly recommend that you have the funds to have that person. It's a really big job. It's critical to being able to pull all the pieces together. You can receive in-kind supports for the team members. That's Lakeland's model. So all of those people that I showed you are in kind, including the health authority provides in kind the SOP and the OT time. The mental health service provider, child welfare provides a person to participate in clinic. And I'm going to talk about what they get out of it in a minute. But often your physicians are paid, unless you can get one to volunteer, but they often still have overhead costs if they run a local clinic or something. So they're still paying out of pocket for, you know, support staff or overhead of some sort. So you're not going to, you know, offer to pay for that, all of that, but to offer something to help to recognize that they're out of pocket some costs. Other clinicians that may not be available locally, you may have to pay on a fee-for-service basis. And in Alberta, psych services are not paid for by government, so we had to pay for those services as well. If you don't have any operational funding, clinics can have a fee. Even under a not-for-profit, you can have a fee to pay for your costs. You would never expect families to cover those costs. Lakeland did have fees at the very beginning. It was $1,000 for children and $2,000 for adults. And we had other departments pay for that, like child welfare, services to children with disabilities, probation, sometimes legal services paid. So it adds another layer of burden to the clinic coordinator and to your administration, but it is a way to kind of get launched. You can physically operate out of borrowed space, so with a community partner, if you want, especially if you're traveling. But you need to consider where your staff are going to work from and where those files are stored. And so home file storage is usually not acceptable for medical files by insurance companies, or you're basically holding the files on behalf of the physician. You're the custodian of those files. And so most physicians don't like them to be stored in a home. This model, the community-based model, can be mobile. So you can take those clinic people and you can move them around to different communities to better serve families. You can imagine from a rural area how much that benefits families. This community-based model also builds a strong relationship with those post-diagnostic supports. So all those community people that are sitting at your table are also providing supports post-diagnostically, or their agencies are. And so it's pretty hard for them to sit there all day, listen to this person's challenges and strengths and their lived experience, and then go back to their office and say, yeah, there's nothing I can do. That's a pretty hard thing for people to do. So you're instilling some action in each of those people. You can certainly reduce the expense and stress for many local families from going to the big centers to get their diagnosis. One of the things that we saw in Lakeland was even those families that were brave enough to travel to Edmonton or Calgary to get a diagnosis, when they came home, they did not tell anyone, because there was no local supports or services, and they didn't know how to approach schools or other agencies to tell their story. And so it also reduces stigma for families when they see local people that are involved, and people that they know, people that they trust. And it certainly opens up, and you'll see, we certainly saw that when we would go to some of the smaller communities and they would see us, that we were just people. We weren't scary, and we would make a point of going out and talking to people that came around. And then we would get flooded with referrals from that community after we'd been there. So what do you need to do to prepare? Well, you need to determine what model you're going to work with. And what your criteria is going to be. You need to recruit those team members, and you need to think about choosing team members that have strong interpersonal and collaborative working skills. Not all professionals, this will come as a huge surprise, but lots of professionals do not work well in a group. And so it's good to find those that enjoy that process and like it and do well. Develop a common vision, a philosophy, principles of operation, you know, how you will work and function as a team, what supports you're going to connect to. Diagnosis is part of the prevention element as well. So how are you going to feed into that? And how are you going to follow the research? So there's a lot of things to work out beforehand. Your approach, developing some policy and management systems. And we did all of this in advance before we started as well. And it really set us up for success that I mean, yes, we fumbled around in terms of the process a bit, but knowing what it was going to be really helped a lot, and really gave families and the other service agencies confidence that we knew what we were going to do. Training is a huge part. So making sure that those professionals that are going to be on your team understand the diagnostic guidelines. Do not assume that they have a good foundation in FASD. Most do not. They think they do, but they don't. So really make sure that they have a good grounding in that. Recommending that they take the CanFASD for sure, the multidisciplinary team training. It's designed for teams to take it together so that they can work through the case scenarios together. I mean, it works if they take it individually too, but it's better if they can do it as a team. And then that all should be followed up with some face-to-face or virtual peer-delivered training. Lakeland had developed training. They've trained most of the clinics across Canada, including those in Ontario, and they can do live cases with you, walking you through. They can do, you know, specific clinic coordinator training, how to set up the files, how do you collect, what's the paperwork, all that kind of stuff. It's amazing. So you need to hire that coordinator. And as I said, this person may need some additional training. They are the glue that holds the whole thing together. They communicate with all the referring bodies, all the team members. They coordinate with the families, all that back and forth. They collect all the information. They track all those appointments. So it's not like they're working through one file at a time. You know, they have 25 files that they're working through. So, and keeping, you know, all those records. and developing a resource list of the community services. And then, of course, we've talked about that, the PAE and stuff. You also need to prepare the community to receive your services. So it sounds like you guys have some FASD services on the ground, and maybe there's been some good training already with community folks about how to serve individuals with FASD, but they still need to understand what you're doing, how to make referrals, and then how to support people afterwards. And for us, this was really important because, of course, everybody was like, what is FASD? Even though we had trained tens of thousands of people in our region beforehand and done 10 years of community awareness stuff. But you also have to help build that confidence that you know what you're doing, that you have the ability, because in a lot of professionals' minds, rural areas are not smart enough to offer specialized services. And so, you know, I'm just being frank about that, but that you do have to overcome that a little bit. And then just preparing the general public to be supportive of you as well, and then preparing your politicians as well, so that maybe they'll give you money. Benefits of diagnosis. I'm not really going to go into this as we're coming up to time, but you can read through it later. So Lakeland did start, I think the first conference and work that they held was in 1994, but as a committee, and then we started to investigate and look at diagnostic services in about 1997. We went for training to the University of Washington. They were pretty much the only game in town at that time to give us any sort of guidance about how to do diagnosis. And then we began in 2000. We began with zero money, no clinic coordinator. We had partnerships though, lots of partnerships. So child welfare provided all the referrals at the beginning, and they also committed to providing follow-up support for each of the kids that we saw. The doctors didn't charge us. The psychologists didn't charge us for the first 6 months. And the clinic coordinator, who was me, and I actually worked for disability services. I did the clinic coordination off the side of my desk and into the evening. And so that was, you know, that was really great team building at that time. Really, everybody was giving something of themselves. But the rest of the committee was working diligently on applying for funding because they knew that that was not sustainable. We just wanted to know if we could actually do it. And so we could, and so the committee was able to get funding, and we opened the center in 2001. So for those of you who don't know, Lakeland is in Alberta, and it's this blue area here with Cold Lake around it. It has 7 First Nations communities, 4 Métis settlements. Alberta has land-based Métis communities, and a military base, and a small city of Cold Lake, and about 25 small towns or more. It's from the furthest tip, it's about a 4-hour drive to Edmonton, and kind of round trip is about 3 hours within the region. And we did travel with our clinic. We did go to many small towns. We held clinics in church basements, in community centers, we preferred to go to like health centers in First Nations communities because they're kind of the hub of the community. But that sure broke down lots of barriers for families, both physically and attitudinally. It was amazing. And it also informed our clinical team members what, you know, the conditions were in some of these communities that people were faced with. And so, you know, our pediatrician traveled from Edmonton, as well as our psychologist. And so, you know, I travel that 4 hours makes you think about what it's like for a family with a child with disability to travel 4 hours to Edmonton for a 15-minute appointment. Really changed their perspective about a lot of things. So as I said, we included diagnostic outreach right from the beginning. And we had to then develop our own model for service delivery for those outreach supports. which was also, quite interesting. How are we going to support them? And we really focused on advocating, helping those families develop their own advocacy skills, because we quickly realized that we weren't going to be able to support them for a lifetime. So where does this take us? So take the time to organize yourselves well, build the necessary relationships that you need, strengthen that team, find ways for them to get to know one another and to build those relationships, and find backup team members too, because not everyone will stay, or things happen, right? So it's always good to have people that are trained and ready to step in. Organize your process, your paper flow, get lots of training, train others. You can consider the prevention aspects, that diagnosis for 2. And if you're seeing young children, you might run into families that are still in the cycle of addictions and needing those prevention supports. It can be easier to start with adults than pediatrics. You need less team members, you're not then in competition with any other kind of pediatric developmental clinic that might be in your area that might feel threatened. Money sure helps. I just want to say a word about physicians. So in a rural area, a local physician, of course, would be optimal, but you need to know that they are worried about ending up with an entire caseload of people with FASD. And this is a real fear for local doctors, and this happens over and over again. So a local physician will show some interest in oncology, and the next thing you know, their entire caseload is cancer patients. And so this is not why they became general physicians. And so you need to find a way to protect them a little bit from that result. So them knowing up front that that there's no expectation for them to do follow-up or anything like that. So just something to keep in mind. Also nurse practitioners have broadened their scope, and they can be involved in diagnostic clinics. And I find that they're very good in the adult clinics. I haven't seen too much in the children's clinics, but I'm sure that they would be excellent there as well. Okay, and just a caution about psychologists. That sounds really ominous, eh? Is there any psychologists on the call? But sometimes we think that all psychologists are trained the same, and they are not. There's many different kinds of psychologists, and so you're looking for someone that is trained clinically and can assess the brain domains that you need them to assess. So for example, counseling psychologists can do a few assessments, but not usually the detail of brain domain that you were looking for. And so it's just something to keep in mind when you're recruiting. So local team members build local knowledge. Local team members take issues that they see in their clinics to their supervisor, and this can create system change. You build experts within government and community organizations, and they can become both your referral sources and your post-diagnostic support. And they can train others within their organization as well. And that helps them to think about that as community partners on a multidisciplinary team like this, that those complex cases that they might be facing alone, they no longer are facing alone, because 9 times out of 10 those complex cases involve prenatal alcohol exposure. And so what we saw on our community-based teams and what others see is that there's a real sense of reduced workload often in some of these cases where mental health professionals or disability services, and so it can be very helpful to managing some of those difficult cases. It really builds interest and pride within your community to have this kind of service available, and it helps to ensure crossover training as well. What we saw at our clinic table was that the team members would take opportunities to talk about other cases and other situations or other work. And so, you know, learning the language that an SLP speaks versus what a social worker talks about, it was huge. And they, when we look back and review some of the evaluations, you know, that is really what they talked about, how they grew as individuals and learning about other, not just about FASD, but about other professions as well. Okay, so FASD assessment and diagnosis is complicated, but it's not rocket science or brain surgery. It's just science. And so we did this, you guys can do this. And this community-based model has now been duplicated. Most of the clinics in Alberta operate this way. Saskatchewan has a number. NWT developed their clinics, their adult clinics this way. Nunavut. So there's lots, and New Brunswick is also, I mean, they have right now a very facility-based model, but they're moving to a community-based model in the outlying areas. So I'm going to stop there because I see that I'm after my time, and we can talk about this other CanFASD stuff if you want after I answer some questions.
So Audrey, once again, thank you so much. When I look at your presentation, I think the one that really resonated with me more than anything else was when you were talking about just how critical it is in terms of the post-service supports after the diagnostic is done.
And so, yes, if you take the training from Lakeland, they've developed a whole clinic model, manual that includes all of all of those reports, as well as, like, you also have to, I didn't get into some of these details, but you have to record how you came to that diagnosis, because if you ever find yourself in court, you need to be able to go back and have that information. So there's some additional forms there that need to be filled out. So yeah.
Wonderful. So once again, we are thrilled to have with us Audrey McFarlane, who is now the Executive Director for CanFASD and the founder and former Executive Director for the Lakeland Centre for FASD. And we invite anyone who wants to get in contact with her. You can certainly reach us at rulefasd@gmail.com, which is spelled RURALFASD@gmail.com, and we would be more than happy to connect you. And that concludes our presentation. We'll see everyone next month.
Thank you.